Right. I'm Chris Cox. I'm a thoracic radiologist and chair of radiology at Creighton in Omaha. And I was just going to kind of go through some of the radiology projects that we have going on. I'm going to primarily present my own projects just because I can speak best regarding them. And with the main idea here of areas where we find collaboration and kind of as part of this brainstorming of where do we develop new ideas in radiology research through collaboration. So I was listening to a talk about St. Thomas Aquinas, and it was the speaker talked about quidsit, and it's basically that our active intellect is always working towards a higher level of order. So it's basically like, what's that? Oh, okay, well, why is that? And what's that? And radiology just lends itself really well to this because we have stored images to look at. And as you're going through, you just naturally look at them and think, hey, I wonder what that is. What's that? What does that mean? Right? And that process lends itself to research. So, and I would say a lot of my research projects come about that way, of reviewing images and just thinking, I wonder why that is. Or the case that's the exception. That's what I really love, is where you think, well, why is that an exception? All right, so anytime I talk about radiology, I also like to touch on this as a little philosophical thing, that this is Plato's allegory of the cave. And if anybody's seen me present on radiology, I think it's even more important when we're talking about research, right? Because I hear people talk about the CT as the truth maker. And I think of radiology more like this, the allegory of the cave, where the radiologist is chained down in the cave and somebody behind the radiologist is casting a shadow up on the wall for us to read. And that shadow that's cast is a reenactment of reality. So it's not even reality itself. And it's not until you climb out of the cave that you really find reality. One interesting thing about that with Plato's cave is the first level of true reality when you exit the cave is mathematics. And I think that really also shows to when we're working through these, what is the truth about the imaging I'm looking at? We employ this higher level of thought with mathematics to figure out whether or not that's really true. So in terms of generating research projects in radiology, certainly for each radiologist that does research, you're just going to generate your own from the images that you see. You're just looking at it and you're thinking about kind of that quidsit. But I will say about half of my projects and projects in our department come from these other areas where particularly multidisciplinary conferences where we're discussing a case and then someone says, well, I've kind of noticed this pattern before. And then, for example, spontaneous pneumothorax in vasculitis patients. We had noticed that, and so we did a study off of that. So multidisciplinary conferences are excellent for generating research. For research interest groups that are new and across multiple departments, we don't have our own radiology research group. And as the chair, I've purposefully done that because I think it works best if the radiologist goes to all the other department research interest groups. And I've actually found that when that happens, the other departments tend to respond with, hey, well, what about this radiology research project? And what about this? And I have some examples from that. And then one thing that we're in the process of working on is this clinical biomedical imaging core. And clinical in the sense that it's not basic science. It's clinical, but still research in its inception, I guess, in its initial form, but will hopefully produce and contribute to the clinical practice. So here are some of the projects that I'm going to talk about. A project that we did related to differentiating nonspecific interstitial pneumonia versus post-COVID fibrosis or fibrotic-like changes. I'm going to talk a little bit about lung cancer screening and some of the projects that were generated from a rig of going to the pulmonary rig. Trauma in terms of working with residents and recognizing things that may increase our detection rates. And then finally, a 3D printing project that we did that led to further research. So this was a study, and this one is actually done in terms of the study itself, but I think it's a nice example, and we have other ones like it in progress right now. But it was kind of this quid sit. You know, you see, oh, I've got this patient who had prior COVID, and they described this subpleural line in post-COVID. And in SIP, we talk about subpleural sparing. And there's a lot of overlap in terms of what that appearance could look like. And there probably is overlap in the actual pathologic process of organizing pneumonia and how it contributes to some subpleural sparing. And that we know that COVID was producing organizing pneumonia. And so we noticed that this distance was consistently broad in COVID and is relatively consistent in its narrowness in SIP. So then we took this as a subpleural distance. I had a pulmonary fellow and a medical student do these measurements. I'll tell you, these measurements are not easy. And so I was a little bit skeptical about this project working. But we found relatively good agreement. I was the tiebreaker for discrepancies. And what we found is if they had NSIP, they had a diagnosis of NSIP, but non-COVID, all right, that the sparing was narrow, the subpleural distance was narrow. And as you looked at the COVID, it was much more broad, but has a fair number that exceeded 8 to 10 millimeters. So then in kind of parsing that out with statistical analysis, we showed that there was a statistical difference in the post-COVID, which had an average distance of 9 millimeters, and NSIP that had 5 millimeters. But I think really the more important point from this was that 34% of the post-COVID patients, if they had a measurement greater than, can't see this behind my, greater than 11 millimeters, that none of the NSIP patients had that. So while that we didn't necessarily show that as statistical significance, a broader research project could essentially do the same thing and then have significance great enough to really set that mark of above this point, we no longer consider NSIP, and it's likely the product of prior COVID infection. So that's one study. Asymmetric fat sign. This was born out of reading out with some residents and having that this was a difficult diagnosis to identify. And going back over those cases and saying, okay, what is it about these cases that are tough to identify? And it's because it's a broken bone, right? So we put it into bone window and then we look for an abnormality in the bone. But the abnormality in the bone may be almost non-existent. Here we've just got a slight bump in the sacral ala right there, but to say that that's a fracture. But if you actually look at the fat tissue in front of that sacral ala, it actually is asymmetric. And you've got this focal fat stranding out in front of it. So it's a little bit of a flip in terms of how we think about fractures, where I'm not so much looking for the fracture as I'm looking for the adjacent soft tissue changes. And that this is a positive sacral fracture. So we're looking at that now, pulling high velocity trauma cases and we have this through IRB. Again, having residents and medical students review the images to identify the finding and see if we've got consistent identification and a positive correlation. So this is just a description of how we're going to go about that. I don't want to go over time now. Lung cancer screening. So this is another one where we've done, this was born out of the pulmonary research interest group, where I went to the meeting, and then it was great. The focus kind of turned to, well, I've noticed this in radiology and this and this and this, and we drew up maybe 4 or 5 projects out of that single conversation, and a lot of them centered on lung cancer screening. So this is one that we're doing as a retrospective review to see if follow-up is appropriate based off of our recommendations in lung cancer screening. And then in that, is there a difference in the populations of people who get adequate follow-up and those who don't? So kind of looking also at equity of treatment once you've identified a potential disease. This was a 3D printing project. I thought I saw Lucas on the list here, attendees. This is one of the medical students, Lucas Betts, who worked with me on doing this 3D print of the tracheobronchial tree. And what we're hoping to do is be able to create a simulation model for the pulmonary department and then introduce pathology into those models for simulation. When we printed it, though, the pulmonologist kind of looked down the barrel of the trachea and said, it's too narrow. And I looked at it, I was like, yeah, I know it is. So it wasn't really accurate. And so what we noticed, well, we went into the literature and found that, well, accuracy for vessels and accuracy for tumors and soft tissue organs, but not for airways. So we're doing a study for what are the parameters in terms of acquisition as well as the patient physical characteristics that may affect the accuracy of the 3D print of the tracheobronchial tree. So here we've just printed a section of the trachea based off of different Hounsfield units as cutoffs. So that would be one of the parameters that we would use to set the airway diameter off of. And what we're trying to do is match it up as closely to the measured image. So this is how we're going about that. We're just going to do 12 patients, but we're going to look at 2 male, 2 female in 3 different BMI classes, and then look at different acquisition parameters, and finally do the 3D prints of 3 different areas of the airways and measure them against the imaging. So there you go as far as the specific aim there. And then finally, the clinical biomedical imaging core. Am I doing okay on time? Okay. The biomedical imaging core. So the thought behind this, and these are at a lot of the big radiology academic institutions, and it's really to facilitate research in radiology. So what we want to do is we want to contribute, to the IRB process as we can with a simple question. Basically, does your research involve radiology? And if they answer yes to that, then a second follow-up question, would you like the assistance of radiology in these different areas, such as budgeting what the use of radiology for your research study, design of protocols, radiation safety for patient consent. Another would be interpretation of imaging, right? So facilitating research for other departments, as well as being a housing center for radiology research tools. We use Empower as a search engine built off of our radiology reports. It would be where we could do segmentation, analytics, and look at purchase of AI products to study. We have already got our 3D printing effort going, and we plan to extend that into AR and VR work. Finally, it also gives us just a kind of a set radiology research space and a place where we could, in the future, have potential personnel and established industry relationships. So that's my whirlwind. I don't know if you want to field questions now or talk, or do you want to go through Dr. King's?
Yeah, let's have some discussion now. You know, I have some questions. I'm excited about your bioimaging core to hear that how that works and how that impacts other research and research growth. But let's just open it up. If you have a question in the audience, go ahead and unmute and speak up. If people are a little bit slower to ask, I mean, when you talked about this, you mentioned Lucas being involved as a med student, and I wonder how, I mean, so I failed to introduce myself as the Associate Dean for Research in the School of Medicine. So in that role, Brianna and I get a lot of students reaching out who want to do research projects. They're thinking about their, future careers. And so, I don't know how many residents involved in the research, how many med students are part of this, how you organize them, if it's a team approach or one-off, and who's driving the topics, the students or the faculty. If you want to talk a little bit about that, I think that would be really helpful for us and the students and the learners all together.
Sure, no doubt. We certainly have more requests for research from medical students than we have projects at this point. Mm-hmm. So what we do is we direct them to Sandy Byers, and she keeps a list of the medical students who have radiology research requests. And then when we have a new project that's being considered, then we go to Sandy and we ask, do you have a medical student who might be interested in this topic? I have found that I think it's really hard for medical students to generate their own radiology research. Like even if they're on rotation, to have enough experience to kind of ask the good question. But I do like is having a medical student tell me, I'm really interested in X, right? I'm really interested in diabetes, or I'm really interested in 3D printing. Mm-hmm. And then as those projects kind of come up, it's kind of natural to bring them into those projects. So I wouldn't say they're generating a lot of ideas. I've had a couple that have been generated by the medical students, and I'm always receptive to that. I don't know, what do you think, Kevin?
So I think that his prior comment about having interactions with other specialties has been the fertile ground. I agree, has been awesome. Like I've been involved with a lot of what's been more like basic or academic research. And the time when I first really got excited was I did a master's, and I was only radiologist in there. It was like clinical translational sciences for young faculty. And it was really exciting to interact with all the different specialties and learn about what they're doing. And oftentimes there's things we can suggest to help them do things better. So it helps build relationships, certainly makes the research we're doing of interest to a much broader swath of people. So I've found that a way for radiology to be able to interact with a lot more people, and not necessarily like somebody's like a student might be coming up with a good idea, but they might, tell me like, hey, I'm working with this guy and he's doing this stuff right there, and what you're doing here might be helpful for that. So as far as like the little feelers, I don't know, the dendrites going throughout the med school, they serve a very important purpose of like telling us what else is going on. Because like Dr. Cox said, we're chained down. We're not walking around doing rounds.
I hope that you're, I'm sure you do too, that this biomedical imaging core is going to increase your reach and opportunities for people to participate in the research.
So I was really interested about that, Dr. Cox. Like where I'm at, I've done image analysis for a while, and I've transitioned over to trying to do medical image analysis. So my talk's going to be over some of that, and starting with neuro. But we have a collaboration going with the trauma service here that's been just really voracious in working with the Creighton students. And I've worked with a number of students already since I've been there, but they have this huge pipeline for doing research. They have this trauma registry, so they have tons of outcomes. And so I'd started doing just a basic project of I can get brain volumes from CT scans. So may not seem like rocket science, but there's a lot of CT scans out there. They just get it, like they hand it out like cups of water in medical centers. So you can study just about anything and ask like, how does atrophy impact? Our question was, how does atrophy impact how people do after trauma? Like there's certainly no old people don't do as well, but we could probably refine that a little bit. And so that's like one way where I can go into something where they already have an established question. Like they're trying to understand how people are doing with trauma. They already have this research apparatus, but we can go in and add additional data and generate tons of, like sort of novel content. They can sort of still go after the same questions, but with a lot of different tools and a more quantitative way. And I'll have to say, I've finally gotten to the point where I have, I think, a critical mass of people that can help me start using some of the AI models. There's an amazing amount of free available AI models. So I was talking with the trauma service and I was talking about the difficulties. They like really laid one on me. I was expecting to get just some old people with falls. They gave me their gunshot wounds to the head, like really horrendous CT heads that have been very difficult to analyze. And I just looked, and RSNA, the main radiology organization, had a research challenge, and not only did they have a bunch of code generated for identifying hemorrhage in head CTs, they also labeled where it came from. They were like, is it epidural, subdural? And I was like, oh my goodness, like we can actually go through and quantify. Like one of the projects, one of our other radiologists, Nick Matthews, who some of you may know, he's a lot more popular than me, and he knows a lot of Creighton guys, but he's in our group. And he was working with them on a really nice question for radiologists, which is like, can we almost ignore small hemorrhages? Like that's one of the big fears in neuroradiology. I'm going to miss a tiny little hemorrhage on the brain, and then they're going to be sent home and they're going to come back and it's going to be huge, right? It's going to be like one of those stories you hear about on TV, like people that have ski accidents and go to an ER and are sent home. But it turns out a lot of them you can just ignore. And so they've done that based off of visual reads, but now we can kind of quantify that. We can actually say like, what's the outcome potentially? So as far as like building up like an analytics core, that's the nice thing about radiology is as long as like that sort of knowledge can be passed back and forth rather easily, and you can collaborate across rather easily for those. And so like they have stuff specifically for abdominals, certainly they have a ton for chest. So as we go through, like, I think that's kind of a nice donut hole is RSNA has been working to develop a lot of these tools. And the people that are developing them, like, they're not usually that interested in the clinical side. These are like computer science groups. So they put it out there and then they probably move on. Like nobody does anything with these. Like I looked and I couldn't find anybody writing papers about like segmenting hemorrhage and trauma patients and significance. Like, I don't know, like they have all these things. So I think that there's a definite opportunity to start using some of these tools. It's just in the past, I haven't done it because like learning how to get your Python environment set up and get your computer set up, it takes time. Getting like at least where we are, getting approval to download a lot of images. The first time I submitted an IRB to get 1,000 images, people freaked out. They're not used to giving people that much data, but once you sort of get those things like pushed down, you can really start generating databases that residents can come on. Like the model I always use, there was a big heart study at UT Southwestern when I decided to get back into research. And so it was started out as a 5,000 person longitudinal study. But if you were a cardiology fellow there and you went into like the research, things where you're expected to have a publication, you would come up with an idea and one of the statisticians there would basically pull the data for you and you'd have the analysis done within a month. And then you'd write it up and that'd be your project and you'd get published. And I don't see any reason why we can't do stuff like that as well. But now that we can analyze clinical data, we can start doing that without having multi-million-dollar studies. Especially if you have other efforts to try to be able to extract data from your from your EMR, which is something that a lot of people are doing, but they haven't started pairing that really yet with quantitative imaging data. They've just mainly been trying to extract stuff from the reports. So there's a lot of low-hanging fruit, I think, for the time being with that.
That sounds really exciting. I mean, I think that I would wonder if, you know, if a time zone and I don't know, 700 miles or however far we are apart is really that much of a barrier for interactions, you know, whether it's learners or faculty on different campuses interacting in this kind of thing. I don't know. I just wonder if, you know, some kind of focused monthly meeting focused on radiology research, you know, crossing campuses, if there would be interest and enthusiasm, and, you know, there might be people in Omaha interested in some of the same questions and increased capacity, and we could support more learners and also, you know, do a bunch of interesting things in that way. I don't know. I would really love to see, you know, more conversation like this. And I think our students would be really engaged in that too. We are on the Omaha campus where we've had an ad hoc committee looking at research computing issues and you know, what support do we need and how do we provide that support. So when you talk about Python and environment, etc., I mean, we do have a computer science department, and, you know, obviously not the medical record part, but, you know, they might be able to provide some support in terms of just the, you know, making sure the programs are installed and working, or whatever coding you need to do for
No,
some
that can be
analysis.
huge. Like when I was in California, I worked a lot with a professor at Pasadena City College. And it's amazing stuff that I can struggle with for a week. You can have somebody that does coding can go in and like literally in like 10 seconds and they know what to do. So that type of interaction can be huge.
We do have one faculty in that department who he's a junior faculty member, but he is so like extraordinarily productive. He seems to have an unlimited capacity for research projects. His name is Stephen Fernandez, and I know he, you know, he really has gotten a number of small grants funded recently, and even as a, I don't know if he was a graduate student or a postdoc before he came, he had a number of grants funded there too, and he really wants to collaborate with medical professionals to do projects like this, I think. So I think that he would be a really great person to connect to.
Great.
You know, I think he'd be really interested. So we can connect him with you, and I don't know. I hope we can have more conversations. We haven't even heard your presentation yet, but
You want me to go through it?
yeah, go for it.
Okay, let's see here. Okay, so let me see. Me have too many things popping up. Let me get this in presentation mode. Okay, so I've been working on this project for a while. There's been some pretty good work on image analysis for NPH. And most of it originally was done, like a lot of image analysis in neuro on special obtained MRI scans. So most research and most people doing work in the field, you get a high resolution MRI of a certain flavor. It's a type T1 high resolution MP rage type thing. And then all image analysis is based off of that, but that's not the norm for what's actually acquired day to day in clinical work. Like even in like neuro in a place like where we're at, people just don't like it. So there's very few, like, I think they put together all of the data sets that are available in the world for this recently, and it was a huge deal. And there was like 100,000 images. And it's like, that's every medical center in the United States. Like we scan that many people. I don't know how long it takes, but obviously like that's not something we have to get together the whole world's resources to get to 100,000. And if you can start getting it from medical centers, you can start coming up with stuff that maybe is clinically useful and relevant to your people. So I've worked with people, I still work with the number of people in LA where I was last, but we've had some really great chance to set up collaborations at Barrow. So let me give you a background on the disease that most of the talk I'm talking about will sort of start from, but it doesn't have to stick with NPH. So I got interested in normal pressure hydrocephalus because it's a type of dementia that's treatable. You can put in a shunt and people get better. So I've been studying Alzheimer's disease for a long time, sort of getting discouraged. And this seemed to me like a very neat thing to come to. And imaging has a very important role. It's very underdiagnosed. And so being able to recognize the ventricles that you're seeing at the top here is huge. The problem is that as people get older and their brain atrophies, your ventricles also get bigger. So it's a hard thing for radiologists to really be able to say, like, is this normal pressure hydrocephalus or is it just atrophy? And the problem is maybe we call it later on, but when people get surgery for this, usually they only get a certain amount better. So you don't go from like being in a wheelchair to walking. You maybe go from a wheelchair to a cane. You maybe go from a cane to walking. So a delayed diagnosis is not good. BNI is great. I came here. They have a ton of NPH. I actually was able to do a search with, they have a really great neuro outcome center that protects from having to deal with a lot of IRB issues. It's awesome. Like the neurosurgeon just sort of created this bulwark so they can do outcome studies and they can change minor variables without having to wait months for the IRB to approve it. And so I've started working with them on that. They have some great data analysts there. Also, it's a great resource. So we just searched the Medicare database for the United States and we were able to find out that we did more surgeries for NPH than any other single site. Like if you put together all the Mayos, they win. But as far as like one site, so we have a lot to work with. We have lots of numbers to work with. I'm going to skip over some of this, but this is a problem. So in the middle here, you have NPH, big ventricles. On the right, you have atrophy, and on the left is what's considered normal for age. And everything in radiology, except for like some stroke stuff now, is still all qualitative. We look at images. I'll say if I think there's atrophy. My neighbor next to me may disagree. If you treat a lot of patients in Beverly Hills, maybe your idea of atrophy is a lot different than if you're, like it's just very subjective. But that's where it sort of stood. You look at it. One thing that's kind of interesting that radiologists do that's very different than the guidelines, though, I noticed. So I think a lot of good research projects start from clinical intuition, is a lot of radiologists will say that if the ventricles are bigger than the sulci, because when you atrophy, you tend to get big sulci and big ventricles. But whenever you have NPH or hydrocephalus, it's more the ventricles are getting bigger. And so these are smaller. So I set out to figure out a way to quantify that. People have looked at ventricle volume before. And if you actually quantify ventricle volume alone, which is like this here, you can separate most NPH because the ventricles get really big in normal pressure hydrocephalus. That's something that clinically people don't really appreciate, but it's very evident when you actually have quantitation. People with Alzheimer's disease that reach this level of atrophy are not really walking around and aren't a diagnostic dilemma. They're probably institutionalized at that point. So you can get a good amount of separation, but there is also a good amount of overlap. One thing I'll keep in mind or point out here, though, is like standard radiology sort of research where they got together certain people. They're dealing with 100 people total, and they only had 36 with NPH. So I wanted to look at our cohort where we have like 400, more than 400 people that had NPH, and that involved us having to look at CT scans for most of them. So with the basic tools that I had learned working with MRI, you can kind of do some pre-processing and make the CT scan sort of look like a MRI for the purposes of the program and sort of push it through and analyze it. So I'm able to take head CT scans, get rid of the bone and fat, isolate the brain, isolate the CSF, and then identify the ventricles. And so with that, we put together a project where we took 300 people that had had NPH surgery, passed a TAP test, everything, the workup, and we compared them with people from the emergency department. So we got 500 emergency department scans and 300 with NPH. And so I'm going to skip over some of this, but basically just going through and doing that segmentation and creating this ratio of ventricle to subarachnoid space. We got amazing separation. So we got an area under the curve of almost like 0.99. So just doing that by itself works really well. So the next project I want to do on this is start using it clinically. We have a thing where we're going to look among our old people at falls, how many look like they have NPH. And then the very next step after that is I'd like to start using this as a clinical tool, like start screening people coming through our emergency department, identifying them if they have what looks like NPH. They should have a questionnaire that we'll have to work out. I'm doing all this in conjunction with neurology, by the way, to see if they actually have gait problems, which everybody with NPH pretty much should have. It's very rare to have NPH without it being gait predominant, and then sending them to clinic. So the thing I like about this is it's not I'm just like presenting something at conference, you know, everybody slaps you on the back, you get a grant maybe. Like I am more excited about stuff where you can actually start using this. Like the main hurdle to using this is all technical, like getting approval to actually download the scans, how we're going to analyze the scans. Getting approval is probably the hardest part of all these projects. But as part of this thing to generate the ventricles for NPH, so this is going on, like it does a pretty good job. We also can do a lot of interesting questions. So as part of that, you go through and you get the brain volumes and the CSF volumes. And so there was an interesting paper published a while ago in NPH where they said the head sizes are bigger. So they're able to quantify head sizes. And so the people at the time said, because head sizes are bigger in NPH, that's the link that they had pediatric hydrocephalus, the sort of BESI, like benign external hydrocephalus of infancy that resolves. So it's some sort of CSF handling problem that persists, and then in adulthood, it comes back as NPH. And so the other project I did with Jacob, who is a med student here at Creighton, this project I am finishing up with Dylan, who's a Creighton resident. And we were able to show that it's actually, the brain volumes are also bigger. So it's mostly concordant. It's mostly actually that people with bigger brains tend to get NPH. And that actually goes a long way towards explaining the sex discrepancy, because brain size tends to go with height. Women tend to be shorter. So there's a floor whenever you look at the data that's kind of interesting, where basically among a certain brain size, that graph's wrong. Among a certain brain size, you basically don't have anybody less than a liter. Well, I changed this to be residuals to make it easier to graph. So it's not the actual volumes. Like it's so this is we learn as we go along. My controls were normal headaches, because like, what's the best thing to get normals? And we get tons of headaches that are all normal. But the demographics are different. Our headache group was younger and more female, and our NPH group was older and male. So I had to do a lot of adjustment. So this is basically adjusting for that. What do you have left over for brain size and skull size? Working with the stats, and basically both the brain size and the skull size is bigger. But if you don't do the adjustment, if you just look at the volumes, the smallest volume we saw of somebody that had NPH was at a liter brain size. So it seems like that can actually help you answer questions. And then using this same sort of technique of looking at the brain volumes, that's the one we're doing with trauma, where we can ask the question, you know, old people coming in with trauma, people age differently. Some old people have almost all their brain tissue left and they look younger. You get a lot of people that are socially challenged, like homeless people, and their brains look like 80-year-olds, even though they're 40. And so I think that the hypothesis there was like, or question, can we do a better job of predicting how people are going to do? Like the factors are going to determine how well they get out of the hospital after having trauma. I think like, and I've done other image analysis projects. Like the next step in this project is I worked with one of the researchers at CHLA. So he came up with a way to automatically measure the callosal angle. That's just like this right here, this angle in NPH, it tends to look more like it's being smushed up the ventricles, whereas in atrophy, everything kind of sags and it flattens out. So I have done like a fair amount of sort of deterministic image analysis where we set out to find things. And so we did this for a couple thousand people on the nation's Alzheimer's cohorts, and showed that it looks like there's NPH in those. So another thing you can do with image analysis is there's a lot of readily available public data sets you can analyze. But I wanted to just stop right there. The thing that I'm kind of thinking is going to be, so I can help you guys out if you want to do image analysis, you're going to get brain volumes. I have a lot of experience with that, and we can do it from CT scans now. So if there's projects that we can collaborate on, like looking at different outcomes for CT scans or screening your population for NPH. I'm more than happy to share code. But the other thing I was talking about, I think I'm gonna have to do a different screen share, because instead of sharing my screen, I shared the PowerPoint. I'm just gonna bring up the RSNA challenge for intracranial hemorrhage. So as I was going through talking with the trauma people and the importance of, like, they gave me a horrendous amount of pathology that I think is going to kind of dwarf probably the effects of atrophy. So like, I think I'm actually going to have to quantify the hemorrhage, and I can do that for my program. Okay. But I remembered hearing a bit about RSNA doing this, and RSNA puts out challenges every year where they basically go through and, like, very clinically relevant things, and they come up with code for how to do stuff. And this is amazing. Like, they go through and they actually classify the hemorrhage by location: intraparenchymal, interventricular, subarachnoid, subdural, epidural, which gives you a tremendous amount of information that then you can pair with that, like in this case, existing ongoing trauma research that already has a lot of Creighton med students working for them, and generate a ton more products. And for that, like, the code, when you go down, they have a listing here of, like, where is it? If you go to the GitHub site, basically right here, they have, like, the top 10 people, and you can download the code. So, I mean, there's a little bit of making sure you have your computer set up the way their computer is set up and running it. But these are all very doable projects. It's just a matter of deciding to set up the time. And the one I gave you is very much obviously, like, around hemorrhage, but there is a pneumonia detection challenge, which probably isn't just specific for pneumonia. Like, and if it can detect it, you can quantify it. So you can start asking questions if you're interested in pneumonia, or you can try running it and seeing, does it pick up NSIP? And if you do, does the volume of it correlate with outcomes? Like, I think we can sort of look at the tools available coming out. And then the radiologists are sort of, the thing we're awesome at is saying, like, hey, they have this tool, great, they did it for this purpose, but we can actually change it around and use it for this other research project that people are wanting to do. Or maybe we can tweak it a little bit and use it for this other project. So that's, like, where I'm sort of at in my work right now. But I'm more than happy to try to help with, I find it very exciting to help with projects outside of neuro. I think there's a lot of potential here.
All right. Wow, that's really interesting. So is there, it sounds like there's a prize for the challenge. So
Well,
there's some
people, yeah, and it's actually amazing. They only had, like, a $25,000 prize. It's actually kind of ridiculous how much they got, like 400 entries. And I'm thinking, like, I am not, if people that are funding me found out how much they could get by putting out prizes, I would be done. Like, they've gotten so much productivity out of these
Yeah.
things. It's really not very much.
So then they leave the code or whatever up there and the results, and then they're freely available, which is
Yeah.
that's such a cool idea. We have some questions. Otherwise, I'll just keep asking and talking because it's altogether really interesting. One thing I will mention, we do have, I don't know if any of them are on this Zoom. They're pretty new, but we have, I think, half a dozen neuroanatomists from Boys Town National Research Hospital that are now Creighton faculty in our Department of Pharmacology and Neuroscience. They are clinical researchers, but they're all PhDs, I believe. But they, you know, I think maybe some connections with those folks would also be really productive.
Laura, I'm sorry. I meant to tie in with one other thing that
Yeah.
Dr. Cox mentioned, was that we were also able to spring out a 3D printing project from this. So normal pressure hydrocephalus, people that haven't heard of it, it's not nearly as well known as, like, Alzheimer's disease. So patients show up to clinic, they don't know what their brain ventricles are, they don't really know what the disease is. So because we're segmenting it, if you're segmenting things, it just means, like, you're identifying the parts anatomy using your program. It's fairly straightforward then to take that segmented object from image analysis and create 3D printing, like he was showing. So we have a project where they generated the brain ventricles, and then they're showing it in clinic, and basically tying it to getting data back out. So I found some other people that had published something using this. It's a nice thing because I kind of handed it off to the neurologist that's been helping me. So it'll be a project that he can sort of show that he's doing with his department. And they'll ask basic questions about how do you understand your disease? How was it better after you had 3D printing? And then they'll generate enough data to say, hey, we were able to show a benefit and get it like at least an abstract. Maybe if the person's really dedicated, you can get publications out of this. So also trying to drill through like for these projects for like residents and med students, like it's very important for them to get something out of it. Like presentations are very helpful for them to get recognition for the work. It's a great way to sort of separate yourself from the academic field, that, hey, I actually got involved with the project and I saw it through to this point of actually presenting something.
Yep.
Uh,
Yeah.
So
That's really interesting. We do have, I think he talked once, John Cote, who's got a 3D printing grant that is looking at maternal fetal attachment with a 3D printing of a sonogram that he gives to some of those mothers. And I think he was like trying to tie it to smoking cessation by increasing the bonding. And it certainly would be relevant for all kinds of other projects as well. That's really interesting. I can't imagine that we don't have hordes of students that are going to be really, you may regret it, depending on how widely the video gets viewed.
on our end, Nick is supposed to be helping with interface, I think, with the med students right now. Nick Matthews is like assistant. And just, like Gridley and I, like, we'll sort of talk more after this, but we have a little bit of a split here between neuroradiology and general radiology, but we like each other, so we can figure it out.
Okay.
But for like neuro, like Nick Matthews and now Raza, we got one of our former fellows, Raza, who was really taking over doing a ton of resident projects when he was at Tucson, University of Arizona Tucson is now here. So I'm very happy to try to figure out ways to set up like groups. And then those can be really awesome because med students oftentimes will have a bit of time here and then not have time. So if you can sort of generate like an intelligent way groupings, like that's kind of where I'm getting the critical mass now. So you can have projects continue to move along, and as one person needs to, go to some rotations where they don't have time, you can continue to move the project along, and you sort of generate pathways of doing things so they can teach each other as they're coming in and coming out. So here, the trauma team here is a great model for that. They have one of their PhD, I think, statistician research support people that runs, I think they have like 10 to 12 students that they have helping them with projects over the summer. So they've made it an organized thing, and they have lectures. I'm certainly not that organized myself, but there's ways to do it to maximize.
I think one of our MD PhD students is at BNI also right now, which that is a group of students who's always interested in more translational clinical research projects. And we have quite a few neuroscientists among the basic scientists as well.
I think there's a lot of opportunity because we don't really have great ties with any undergraduate place here. There's supposed to be some ties between here and Arizona State, but I haven't really seen much of that myself. I think it's sort of ripe for more collaborations.
Yeah. Well, in our PhD programs also, I think, I don't know. I don't know what the next best step forward is for continuing the conversation and thinking about building ties, whether you guys would be interested in setting up a subsequent meeting, and we'll try to get some of those other, faculty that might, really have overlapping research interests. For sure, I'll get you in touch with Dr. Fernandez because I think he's a natural complement to the AI stuff you're doing. That's really his area.
I mean, having these webinar things, these Zoom meetings is a great first step because the biggest option oftentimes just knowing what people are doing.
Yeah. Yeah, I think maybe we should have another focused one on this topic that, like, I don't know how to structure that, but, you know, spend more time talking about the projects going forward. Dr. Tierney, who I think has a conflict today, is our Associate Dean for Clinical Research and Public Health. And she and her team are working on some different sorts of workshops to help faculty gain research skills. I think most of those are virtual, but, you know, being able to connect people who are like just beginning with those who are moving stuff forward and get them plugged into projects. And I think especially our cross-campus connections. All right, I'm going to be quiet. Are there any comments or questions from our audience? Okay. Well, any last thoughts? I guess we'll be in touch. We'll set something up, and we have our research networking event for our M1 students. It would be great if Lucas could be there to talk to the incoming M1s about the work he did. And, you know, Chris, maybe some of your students from the Omaha campus, to provide some, you know, conduit for those up and comers in getting plugged into projects.
Absolutely.
Okay, sounds great. We have Sandy Byers here also. She and Brianna Conyers, both of their emails, you know, you can get to them by writing their name at creighton.edu. If you would like to put your name in the hat to become a faculty mentor, or if you're a learner and you'd like to get connected to a faculty mentor or a project.
You can also use researchacademic@creighton.edu. It's easier to remember probably than everybody's names.
Yeah, or SOM research@creighton.edu.
Or SOM research@creighton.edu.
Two
Yeah.
of those.
Either one, and then we'll connect with each other on making sure you get to the right spot.
Yep. All right, well, thank you both so much for some really interesting work. And I'll say, you know, in my leadership role, thank you both so much for supporting our learners also, and, you know, pushing the frontiers of our understanding and, you know, of the science forwards for better medical treatment and outcomes. It's exciting stuff. So we'll
Thank you for the invitation.
You're welcome. And I'll hope to see a number of you next month at our next session.
Thank you.
Thank you.
Have a great weekend.
Bye-bye.